Okay, think we can probably get started. We got some folks filing in now, and they'll continue to file in as we get started. So to keep everything on time, we'll get started. So welcome, one and all. Thank you for joining us for today's webinar, Pharmacy Without Borders. This webinar is sponsored by BCT Partners and Envision America. I'm David Raystrick, and I'm president of Envision America. So some 28 years ago, I founded this company with my father, really out of the needs of family members. My uncles had what's called RP, or retinitis pigmentosa. And what that means is right around 45, they had a tunneling of vision until really they had no usable vision. And so blindness was kind of our family normal. And my dad and I founded the company really focused on the needs of these folks with vision impairments. But we have evolved to help folks that have other challenges in a changing world. But our focus is on healthcare and pharmacy. We are the developers of Script Talk, which is a audible reading prescription device. We've started out working with the government agencies like the VA, and we've since spread out, and we have thousands of pharmacies. And in fact, there's about 10,000 pharmacies using Scriptability, which is our platform to do accessible labeling. So enough about me and enough about Envision. Let's talk about the webinar and just kind of what we're going to do today. So since 2016, the American Council for Pharmacy Education mandated some cultural competency training for pharmacy programs. And their focus was many things, but really to make sure pharmacists do more around diversity. They wanted to also focus on health disparities and how pharmacies deal with health disparities. Um, Thirdly, they wanted to look at applying linguistically appropriate care and pharmacies doing that. So let me just kind of distill everything down here. What this goal is for this talk here and for this webinar is we're going to talk about the emerging challenges and give pharmacies really practical tools to better serve diverse populations. We want you at the end of this to feel really equipped to provide culturally and disability appropriate care. Ultimately, we want you to foster trust and better outcomes with these groups. So that's what we're going to do. So we'll kind of talk through these topics for today. Again, understanding demographic changes and what they mean to pharmacies and what are their implications. We want to look at health disparities, both disability, racial, ethnic disparities in pharmacy. We're going to discuss language access and providing, again, that term linguistically appropriate care for folks. Fourth, we're going to look at regulatory requirements, especially around language is where we'll focus there. We also want to talk about pharmacy encounters inside the pharmacy. In an increasingly diverse world, how are you handling disabilities? How are you handling language access? But really, in a broad sense, we want you to come away with what the future holds for diversity inside pharmacy. So with that said, that's what we're going to do. I want to take a quick poll real quick to start things out. So if we could put that poll up, what we want to do is find out more about what your role in a pharmacy is. So can we pop that up? Is that there we go. So what is your professional role? If you wouldn't mind answering this question so we can all kind of get a sense for where everybody is with regard to their role. Okay. Terrific. So we can all, let's go ahead and end that poll if we could. Okay. Thank you for that. That kind of gives everybody an idea as to all, who all is here. So thank you for that. So let's real quick now dive into our speakers for today. Not first on the list, but first up here is a gentleman by the name of David Hunt, and he is the Senior Director for Health Equity at BCT Partners. Now, David has been working for about 30 years in diversity, equity, and inclusion, working in hospitals and health plans. He'll talk about a changing world and give you some ideas on how pharmacy can respond to shifts that we're starting to see happening. He'll also discuss the new Section 1557 in the Affordable Care Act, something that every pharmacy should know about, what it says and how to comply with its provisions. So, David, we're excited to have you here. We're also going to hear secondarily from Charla Glass, who's been working in this space for 20 years. She does work with Envision America, works closely with me. Charla's helped to pave the way for a world that includes accessible prescription labeling. She's our community outreach liaison. We're very proud of her and works with advocates doing grassroots style outreach. So again, thank you very much for joining us for the presentation. We've got lots to cover in addition to a good amount of Q&A at the end. So let's get started. David Hunt, if you're ready, let's learn about working in a pharmacy without borders.
Okay, let's do it. Dave, thanks for that nice introduction. I'll just mention a little bit more about my own background and the background of BCT. The preceding slide mentioned that I'm an attorney. I practiced employment law and civil rights law for a number of years. I have been doing DEI work all across the country for the last 30 years. I'm nationally known for my expertise in racial and ethnic disparities, cultural competence in healthcare, the law of language access, which I'll be talking about today, and then global medicine. Importantly, I am the Senior Director for Health Equity at BCT Partners. BCT Partners, just briefly, is a national management consulting and training company. We're based in New Jersey. We're a Black-owned company, very proud of that, and have been very involved in the health equity area. I lead our national healthcare health equity practice together with my friend and colleague, Rika Salonen, who is also on today's call. Next slide. Just wanted to, and I'll cover this just briefly, but just wanted to make sure that everyone is aware that today's webinar is really intended to be educational. It's advisory only and should not be relied upon as legal advice. Having covered that, I think we can now quickly move on. Dave mentioned that we're going to start off by talking about 3 demographic megatrends. And I'm a firm believer that demography is destiny, right? So the 3 demographic megatrends that I want to talk about in today's presentation are these: issues of race and the changing racial and ethnic composition of our country. Secondly, language, as it pertains both to limited English proficient and deaf and hard of hearing individuals and other individuals with disabilities. And then third and finally, we're becoming not just a multilingual country, but a multicultural country. And so we'll talk about trends related to immigration and culture and how that affects pharmacies today. So I want to start with the next slide, which begins to talk about our first of those 3 changing demographics, which is race, right? So as you can tell from the bar graph, the US population is rapidly changing. By 2040, we're expected to be a minority-majority country. You can tell that very quickly just comparing 2010 to projections for 2050. The white population in the United States is expected to shrink from 65% in 2010 to 46% in 2050. The Hispanic population is set to virtually double from 16% to 30%. The Black population is expected to stay approximately the same, about 12% of the population, and the Asian population is expected to increase substantially, in addition to individuals who claim more than one racial or ethnic identity. Next slide. So this tees up for us the topic of racial and ethnic disparities. This topic rapidly came to national attention in 2003 when the Institute of Medicine published a clarion call to address this topic of racial and ethnic disparities. They published a report called Unequal Treatment, which you can still find out there on the internet. I commend it to your study. But in a nutshell, that report concluded that people of color receive lower quality healthcare than whites do, even after we adjust for insurance status, income, age, and severity of conditions. You can hold all those things constant, and still folks of color receiving the poorest quality care in our hospitals and clinics. That basically suggests that our fastest growing populations are receiving the worst care in American healthcare. Those findings from 2003 sadly have not improved much. Every year, the Agency for Healthcare Research and Quality publishes a national disparities report. And as you can tell from the bar graph there at the right, those disparities have not improved over time. This is the latest data that we have from the most recent report in 2023. And you can tell that for most of the conditions that were compared for folks of color as compared to whites, those disparities have only been increasing or been made worse. Now, much of that is due to the increase in disparities during the COVID pandemic, but nevertheless, right? So next slide. Very important to underscore the role that all of you have in reducing those disparities. We know, I know, I'm sure you do too, that there are more than 60,000 pharmacies across the United States today. 90% of US citizens live within 5 miles of a pharmacy, and many offer health services at lower costs than other providers. Data shows that patients see their pharmacists 8 times more often than their primary care providers. And so pharmacists often serve people through patient education, counseling, community outreach, and so forth. Next slide. We know, and again, I know you do too, that pharmacies can mitigate structural inequality through healthcare services such as administering vaccines and providing oral interpreters, written translated materials, which we're going to be talking about, as well as audible and braille drug labels and instructions, which Envision is really known for. Next slide. We also know when it comes to disparities that pharmacy deserts primarily affect communities of color. There's been a really interesting new initiative that we call the Pharmacy Access Initiative. It's coming out of the University of Southern California. And basically what they've done is they are mapping where these pharmacy deserts are occurring. And I'll show you some of the fruits of that research momentarily. But what the research is telling us is that approximately 25% of neighborhoods in the United States are pharmacy deserts, many of which are populated by communities of color. Black and Hispanic neighborhoods have the fewest pharmacies, and they are more likely to experience pharmacy closures. And research also tells us that people who have prescriptions filled at a pharmacy that subsequently closes are more likely to discontinue their prescription drugs, having a negative impact on their ultimate health and outcomes. So the next slide, this slide is a slide from that Pharmacy Access Initiative that I mentioned. This map is from the LA and Long Beach, California area, and you can tell that the hot pink areas, and particularly the brown areas, are the areas where we see the highest concentrations of pharmacy deserts, and most of those are in Black and Hispanic neighborhoods. Next slide. The second key demographic megatrend I want to highlight is changing demographics with respect to language, right? So again, as we look out across the United States today, 21.5, almost 22% of US residents, that's 68 million of us, speak a language other than English at home. Now, a subset of that population, 8% of the US population, about 30 million of us, are limited English proficient. And we call out that term because folks who are limited English proficient have a legal right to language access services under American law. Today, around our country, over 350 different languages are spoken throughout the United States. So you can see what a challenge that is. The United States today is more linguistically diverse than all of Western Europe. That's the case right now, right? Pharmacies struggle to serve LEP patients. What we know from the research is that about 47% of pharmacies never or only sometimes print non-English prescription labels. 54% never or only sometimes prepare non-English information packets. 64% never or only sometimes verbally communicate in non-English languages. 11%, and I would bet that that percentage is actually higher, use patients' family members or friends to interpret. As a result, only 55% of pharmacists were satisfied with their communication with patients with limited English proficiency, and we'll see why that's the case in greater detail here momentarily. But I want to pass the baton at this point to my colleague Charlotte Glass from Envision. Charlotte, take it away.
All right, thank you. As Dave mentioned before, I've been with Envision America for almost 20 years and working with patients and advocates. And in that time, I have heard many stories of people's experiences managing their medications with either a vision impairment or a limited English proficiency. And so we're just going to have a little case study here and share one of the experiences of a patient that I spoke to. This one is about vision impairment. So in this particular case, the blind patient used paratransit to get to her pharmacy. Now, if you're not familiar with paratransit, usually you have to make a reservation, but they don't always arrive at the time that you reserved. So on this particular day, they had to wait an hour and a half beyond their reservation time, which meant that they arrived at the pharmacy fairly near closing time. And when they arrived, they found out that their accessible prescription labels were not ready. In fact, there was no pharmacist there that day that had been trained on how to create those. And so they said, well, you'll just have to come back tomorrow. And because it was closing time, they closed the pharmacy and left the patient waiting outside for paratransit. And again, so this was a blind patient who was also using a wheelchair. And they were just left there as everybody went home, and they were supposed to come back the next day. So there's a lot of different issues that are in this, and we just wanted to open up the chat and get your feedback on some of the issues that you see there and why you think could have been done to prevent it from happening again. So go ahead and share your ideas in the chat. Okay, well.
So again, Charlie, your question is what could have been done to prevent this?
Yeah.
Is that kind of the gist?
Yes, yes. Thank you, Jamie. Yep, having more pharmacists trained is definitely one thing. Thank you. Okay, planning ahead. Yeah, that is another thing that if everybody had planned ahead a little bit better, if you know you're going to use paratransit, do it earlier in the day, but also have the labels ready ahead of time. Okay, this Matt says, could she have used a pharmacy that has delivery or mail order? That is an option, unless of course it's a Schedule II drug or an antibiotic or something like that, an acute medication. You can't really have those filled. Yeah, just basic compassion. Thank you, Porter. Yeah, so those are all a lot of things, and a lot of people are liking that one as well. Yeah. So next slide, Rika. Thank you. So I'm just going to talk a little bit about some of the practical solutions that we encourage pharmacists to do. And a lot of the pharmacists that we work with are doing these things. So this is just in this slide, just a quick overview. Staff training, flagging in your EHR, translated patient information sheets, alternative formats, labeling, interpreter services, and then David's going to talk a little bit about the teach back method. Next slide. So when it comes to reoccurring staff training, this is so important. And a lot of people are trained when they're onboarded or maybe when they went to pharmacy school. But it's so important to continue to train staff to be able to use the policies and procedures that you have in place. And so not just on cultural competency, but on the methods that you have. So if you have a language line, everybody in the pharmacy should know how to use the language line and should practice so that when someone comes in, it's not the first time that you've ever done it. Being familiar with interpreter services and translation services and, accessibility services. For example, if you provide script talk labels, does everybody in your pharmacy know how to do that? And be familiar with it. What is an interpreter going to expect from you? And patients that are used to using an interpreter, what are their expectations? And then finally, going back to the social determinants of health, really working with community organizations to train your staff so the cultural needs of your particular community, working with cultural community centers and that kind of thing, so that you can really be very specific in what your community needs. Next slide. Now, when it comes to electronic health records, this is something that we've seen a growing number of pharmacists utilizing. You can add a language preference field or a disability needs field, and then have a pop-up flag. So whenever you fill for that person, the flag pops up and reminds the pharmacist or the pharm tech or the clerk, that this patient is going to need an accessible prescription label, or this patient is going to need an interpreter. And that way, when you're filling, you're alerted, and then you can plan ahead and say, okay, team, sometime today, this patient is coming in, and these are the services they're going to need. And then finally, I have read that NCPDP has already penciled in to future script standards the ability for prescribers to inform the pharmacy ahead of time that language access is needed. And I think a lot of pharmacists are going to really like this when the prescriber includes that in the prescription information. And some EHR and prescribing software already have this built in, but it's not, one of the current standards. It's going to have future of the standards. And so we might see that increase as we go on. Next slide. Now, patient information sheets, I know you all know that these are really important, and they're also annoying because it's a lot of paper that people may or may not read. And the people who read them find it very important. And the people who don't often just set them aside or throw them away. Now, if you are limited English proficient and you're getting your translation in this manner, then that's great information and you're getting it translated, but it's not on the bottle. And so this image that's in this slide is a real life image taken by a nursing student when she went to visit her in-home visits with her immigrant and refugee patients. And this particular patient was afraid to throw the important paperwork away, but he also couldn't read it all, and it was totally separated from all his meds. And he just saved it in this corner. This is what happens. And so this is why we at Envision America are very adamant. You need to have that translation on the bottle because this kind of thing can easily happen. Next slide. Here's some other reasons. Even if you do provide counter counseling with an interpreter, nobody remembers everything. That's just because we're human, but also when you go to the pharmacy, it's one of many errands that you're running that day. You might have kids. You might feel sick. I remember when I went straight to the pharmacy after being in the ER, and I felt horrible, and I was feeling like I was going to pass out, and I'm just waiting for my meds, and I'm like, I would not remember anything that they told me. It was a good thing that the warnings and everything were on the bottle. But everyone refers back to their bottle to get that information. And then finally, well, there are two other things. People's needs change. So, if someone has some vision impairment, it's very possible over time that they will lose more vision. And so they might have been okay with a large print label in the beginning, but then over time, that might not be a solution that works for them anymore. Or for example, as someone ages, they might have learned English when they first immigrated to the United States. But as they get a little bit of dementia, they might actually lose a lot of their English and revert back to their native tongue. And in that case, they might need to go back to having some kind of translation provided. Finally, a lot of refugees that come to the United States, especially from countries where women are not allowed to have an education, they don't know how to read yet. They might be learning English, but they're also learning to read at the same time. And that's not something that you can just do right away. That obviously is a process. And so some immigrants and refugees might benefit from an audible prescription label in their native language. And we're really excited that that is something that we can provide. Next slide. So here's another patient story to hit this home. This particular patient, I remember talking to them, and they had accidentally given their guide dog their medication, and she took the guide dog's medication themselves, and both the guide dog and the patient ended up in emergency care. And somewhat jokingly, but very distraughtly saying to me that it's fine if I would have died. I wouldn't have minded. Like I wouldn't have known. But if my guide dog dies and I survive, I lose all my independence because it's really hard to replace a $25,000 guide dog. And if she doesn't have her guide, in this case, the man doesn't have his guide dog, he cannot go to work. Like that is how they walked to work every day or got to public transportation and so forth. So, being able to take your meds is not only just about your health, it can also be about your entire livelihood and independence for some of these people. Next slide. And so we really stress, and the United States Access Board in 2013 also created some best practices that said, this prescription label information really needs to be on the bottle, so it's not separated. It needs to be given to patients in a timely manner. Really, according to the Americans with Disabilities Act, patients who are getting an accommodation should not have to wait any extra time compared to other patients. So they shouldn't have to use a mail order, and they shouldn't have to wait longer. It should be in a timely manner. And then it should be in a format they can access or understand. So we can't just give every blind person a Braille label because only 10% of blind people read Braille. And we can't give, again, like an immigrant or refugee who doesn't know how to read, giving them a translated label isn't going to help them either. So those are some of the standards. And of course, including the instructions and warnings is important. Even if they know what the drug is, not having those instructions and warnings can lead to serious health effects. So, next slide. So this slide is a little image of the solutions that we provide through our Scriptability. Scriptability is our software platform, and it can stand alone, or you can have it integrated into your software system. It works either way really well. It only takes a few moments to program one of these kinds of labels for your patients. So the first one is our Script Talk RFID, and you're actually just programming a little RFID tag that goes on the bottle. Then these can be programmed in English or 24 other languages. We also have this standalone device that can read it. This is really great for a lot of the seniors or newly blind that do not have, they're not tech savvy. They haven't learned how to use a smartphone yet. But we also have a smartphone app, and it works really great. And I'm going to just do a quick demo here so you can hear what this talking label sounds like. So you just hold up the RFID tag to your phone. Hold on a second.
Paciente, John J. Smith. Medicamento, amoxicillin 500 miligramos tablet. Instrucciones, tomar 1 cápsula 3 veces al día todos los días. Cantidad, 30. Fecha de despacho, enero 10, 2024.
It gives you an idea there of And the great thing about using the smartphones is, it just knows what language that you have it programmed in. So then the second image here is our large print label. This you can print up to a 26-point font, so whatever size your patient needs. And we also have dual language available in this. So you can do it all in English or you can do dual language, you can pick. And this is like, if you can see there, it's kind of a booklet style. So I have one here. There's multiple pages that can print. So you can print as many pages as necessary to get all the information on there. And then our final label option is our Braille. And it's a clear Braille overlay. So you can still see the legal label underneath of it. And you can print up to 5 rows of information. Now, that's not going to give you enough space to do the entire prescription label, but it is enough space to give the basic instructions and the name of the drug and so forth. And then, of course, there at the bottom are a sampling of the languages that are available. Next slide. Finally, and what you probably all are struggling with is providing an interpreter at counter counseling. And I just want to reiterate that everyone should know how to use your language services. And I just had firsthand experience in this because I had a patient call, they wanted to speak in Spanish, and we had just gotten a new language line and I didn't know the information on how to use it. And I struggled and it was frustrating for both of us. And so I know personally how important it is to, practice ahead of time so that you can do that in a very fluid manner when someone comes up. And one thing that can help, because if you're not really great with languages, you might not know what language your patient is speaking. Having an I speak sheet or a poster that says these are the languages we provide is a great way to, just have that available on your counter or hanging next to the counter. And then they can point to the language that they need an interpreter for. And I just also want to say that, interpretation is not just so that your patient understands you. This is also so that you can understand your patient better. And I know all pharmacists really care about their patients so much. But, when you use a family member as your interpreter, they're putting their own bias in there, whether they think mom or dad or brother, sister, whatever, need this medication. And their own feelings and everything. And they tend to reduce what you're saying down to what they think the other person needs to know. So having a true unbiased interpreter can be really important too. And I think, David, you were gonna take it from here.
Happy to do that. Thanks, Charlotte. Next slide. So I wanted to offer you some quick tips for working with interpreters. This may seem basic on its face, but a lot of medical schools candidly don't provide this level of instruction on this vital topic. One of the things we know from our research is that about 1 out of every 4 physicians around the country have never had any formal instruction on how to work with interpreters. And it's even worse, anywhere from 1/3 to 40% of providers have never had any formal instruction as to how to work with interpreters for deaf and hard of hearing patients. So a couple tips on working with interpreters. One is make sure that you position yourself so that you face the patient rather than the interpreter. Maintain consistent eye contact with that patient. Try to stay focused on the patient even when the interpreter is speaking. Speak in the first person. Pause frequently to allow that interpreter time to catch up with you. Really try to avoid medical jargon and acronyms. That really messes up patient understanding. Check for patient understanding by using the teach-back method. I'm going to talk about that momentarily. Make sure that you plan ahead and take extra time. We know that these conversations do take extra time. Direct your questions or inquiries to the patient, not to the interpreter. And inform the patient first when you need to ask the interpreter a question, and then don't interrupt the interpreter when they respond. Finally, it helps to have a pre and post-patient discussion with the interpreter, so you know going in a little bit about what you're going to encounter, and some tips and tactics having had that conversation. Interpreters can really be your partner here, right? So next slide. So this is kind of one of my favorite slides, because I think providers oftentimes assume that limited English proficient patients leave these in communications or encounters understanding a lot more than they actually do. In fact, there was some research a few years ago that asked providers directly, hey, how much do you think your patient understood, your LEP patient, how much do you think that they understood of your diagnosis and treatment plan by the time they left your office? Those providers responded, oh, about 80%. Well, then the researchers asked their patients, their LEP patients, and the LEP patients reported that they understood less than 40%, right? So just a key tip not to make assumptions about what patients are understanding. And here on the next slide is actually a nice little tool that you can use to confirm patients' understanding. We call it the teach-back method. It's a very simple little process to ask your patient at the end of the clinical encounter to repeat back in their own words their understanding of your diagnosis and treatment plan, right? That serves two really critical functions. First, if you do it correctly, it establishes that your patient understood and that effective communication has taken place. Secondly, from a legal standpoint, if you can demonstrate that effective communication has taken place, you have discharged your legal duty to that patient, right? So really important to use that teach-back method, right? So let's go to the next slide and we'll give you some examples of how to use this, right? So a couple of examples of some teach-back starters would be this. Pharmacist says, I want to make sure I explained everything clearly. Can you tell me in your own words how you plan to take your medication? Or can you show me how you plan to use your inhaler, right? Really important to ask open-ended questions when you use the teach-back method and not use closed-ended questions. So really try hard to avoid questions like, do you understand? Do you have any questions? Don't do that. Ask those open-ended questions. You'll get a lot of information in return. Next slide. It's really important to understand that poor language access services can be linked to poor patient outcomes. The biggest problem in this area by far, from a quality and safety standpoint, is failure to use qualified medical interpreters, right? The research tells us that when pharmacists or other providers use untrained, unqualified family members or friends, or God forbid, minor children, there's an average of 33 mistakes per patient encounter, right? So poor language access services are linked to poor medication adherence, medication errors, permanent physical injury in patients, increases in patient mortality. The Joint Commission, which is one of our clients, would readily tell you that failure to use qualified medical interpreters increases the chances of permanent physical injury or even death by a factor of 30% to over 50%. Poor language access services are also linked to higher rates of hospital admission, emergency room utilization, unnecessary medical tests, higher rates of hospital readmission, breaches in patient privacy and confidentiality issues, HIPAA, in other words, and finally, lower patient satisfaction scores. So a lot is riding on language access. Next slide. Just another quick little case study. In this case study, a toddler was taken to a pediatrician's office by her parents. Her parents were LEP, limited English proficient. The child was diagnosed with iron deficiency, anemia, and prescribed an iron supplement. The parents took the prescription to a local pharmacy that didn't provide language services. The prescription label on the bottle was provided in English. The pharmacist attempted to demonstrate the proper dosing and administration of this drug. 15 minutes after the patients administered the medication to the child at home, she appeared ill and vomited twice. the child was taken to an emergency room where it was discovered that the parents had administered 15 milliliters when the proper prescription was 15 milligrams, a 12.5-fold overdose. Next slide. So there are important business reasons to provide language access. There are important medical quality and safety reasons to do language access appropriately. There are also important legal issues that you need to be aware of, because pharmacists are subject to a host of federal and state language access laws. The granddaddy of all those laws is Title VI of the Civil Rights Act of 1964. That guarantees language access to limited English proficient patients. In the United States, you don't have to be a United States citizen to have language access rights under American law. If you're limited English proficient, you have a right to language access services. The Americans with Disabilities Act was the first major piece of federal legislation that offered language access rights to the deaf and hard of hearing, and as well as to the blind and vision impaired. Other federal laws include OBRA, HIPAA, and now Section 1557 of the Affordable Care Act, which I'm going to talk about in more detail in a moment. But it's also important to remember that there are both federal and state laws that apply specifically to the pharmaceutical industry. Federal and state drug labeling laws, state pharmacy laws, many of them have counseling obligations which require you to counsel your LEP patients in their language. Next slide. So what's new in this area from the standpoint of the law? Well, Section 1557 of the Affordable Care Act has been on the books for some time, but the regulations that implement that act continue to change, and we saw big changes this year coming out of the Biden administration. It's important to understand that Section 1557 is an anti-discrimination provision of the Affordable Care Act that relates directly to healthcare. It reinforces prior anti-discrimination laws on the basis of race, ethnicity, national origin, which is where language comes in, age, and disability, all as they apply to healthcare. What's new about Section 1557 is that for the first time, they add new anti-discrimination protections on the basis of sex. Now, that terminology has been used consistently in emerging US Supreme Court decisions. So on the basis of sex includes or prohibits discrimination on the basis of sexual orientation, gender identity, sex stereotyping, sexual characteristics, including intersex traits, pregnancy and related conditions, and discrimination on the basis of marital, parental, or family status. Think the LGBTQ community for a moment, right? So next slide. So who has to comply with Section 1557? Basically, if you're a healthcare organization that accepts Medicare or Medicaid, you have a legal duty under the law to provide language access. Covered entities subject to Section 1557 include just about all healthcare providers. It includes hospitals, health clinics, physicians' practices, nursing homes, pharmacies, health insurers and plans, home health agencies, and others. Next slide. What, in a nutshell, does the final Section 1557 rule require? If you're an organization that has more than 15 employees, you have to appoint a Section 1557 compliance coordinator. You have to train relevant staff on Section 1557 and its anti-discrimination provisions. That specifically includes organizational leaders. For big organizations, that includes all of your C-suite officers, including your legal counsel, your CEO, CFO, so forth and so on. It requires that you develop civil rights grievance procedures and keep strict records about any complaints on civil rights grounds. That you develop specific written policies and procedures to implement non-discrimination requirements and language access programs and procedures. So you should have written policies and procedures that deal both with limited English proficient as well as deaf and hard of hearing patients. In addition, you're required to disseminate notices of non-discrimination and notices of the availability of language assistance services and auxiliary aids and services. And there's some technical aspects of that, which I won't get into. And finally, you're required to provide written assurances to the Department of the Office of Civil Rights that your organization will provide health programs and services in compliance with Section 1557. Briefly, then, on the next slide, you can see some of the effective dates of these new rules. A good number of them have already taken effect. They took effect as of July 5th of this year. Some additional regs came into effect just within the last week, November 2nd. Virtually all of the new requirements will be in effect by July 5th of next year. Now, when it comes to the Q&A, we can talk more directly about what effects the election may have had on Section 1557 and these requirements, but I'll leave that to our discussion going forward. Next slide. So, in a nutshell, one of the things that I'm always asked is, what's the no-no list, right? What can't we do? What does the law specifically prohibit us from doing? So if you want a quick crib sheet, covered entities, pharmacies are specifically prohibited from requiring individuals to provide their own interpreter. Can't do that. Illegal under the law. You cannot require individuals to pay the cost of their interpreter. You can't coerce individuals to decline language assistance services or coerce individuals to accept language assistance services. You can't deny language assistance services to companions. They've got a right to language access services too. So family members, friends, partners, or associates of people seeking care also have a right to language access. It's really important, and one of the most critical requirements under the new Section 1557 regs, to use qualified medical interpreters. So using non-qualified medical interpreters, in other words, adult family members, friends, except as a temporary measure in emergencies, or if the LEP person requests it, is illegal under the law. Finally, using minor children for a whole host of good reasons as medical interpreters is banned except as a temporary measure in emergencies, and that exception should be strictly construed. Next slide. So remember, there are two populations that have language access rights under American law. Limited English proficient patients have those rights. Individuals who are deaf and hard of hearing, as well as individuals who are blind or are vision impaired, also have language access rights. So when you're communicating with individuals with disabilities, really important, just as a general principle, that communication with individuals with disabilities, including their companions, should be as effective as it is with non-disabled individuals. Covered entities must develop and maintain effective communication procedures and provide auxiliary aids and services, including qualified interpreters, qualified readers, real-time captioning, video phones, large print, which Charla has mentioned, audible labels and instructions, Braille materials, which I know Charla and Envision America also provide, right? So there to help you. Next slide. Is a pharmacy liable if it doesn't provide language services to LEP patients? The answer to that question is absolutely yes. Absolutely yes. If a patient suffers medical harm caused by a pharmacist, the patient could initiate a medical malpractice or negligence claim against the pharmacy or pharmacist. Important to remember that language access violations are civil rights violations. And civil rights violations are not typically covered by medical malpractice insurance. So oftentimes this is an area where folks are going bare. Don't let that happen to you. If the HIPAA privacy rules are violated, a pharmacy can be liable for fines of $100 per violation or up to $25,000 per year. So let's say that you encounter an LEP patient at your counter. You don't, for whatever reason, provide language access services. They're speaking to you in Spanish. You don't know Spanish, but another patient pops up and says, oh, I know Spanish. let me interpret for you. That could easily be a HIPAA violation, right? So important to keep that in mind. And then remember, it's not just federal laws we're talking about, we're also talking about state laws. And virtually every state has language access laws. And additional liability can apply under those state laws. So for example, under New York law, failing to abide by the requirements for labeling and counseling a patient in their own language could result in a pharmacist facing misdemeanor charges with fines and possible jail time for multiple violations. So this is an area of the law that you want to make sure that you're in compliance with. Next slide. How can pharmacies pay for language services? Currently, 15 states offer payment for language services under Medicaid and SCHIP. We've listed those states there. So forth. There are some provisions for that, and in some cases, you can actually deduct some of the costs of this on your taxes as a business expense. Next slide. The third and final demographic megatrend that I want to talk about is changing demographics as they apply to immigration and culture. Again, our nation is changing. There's been a lot of conversation about that during the last election, but here's what we know statistically. By 2019, virtually 14% of the US population were foreign born. That percentage increases to over 25% when you include the children of immigrants. The foreign born population is expected to double by the year 2060 to a total of nearly 78 million folks. So immigrants and their offspring will likely account for 88% of the population growth over the next 40 years here in the United States. Next slide. When you are caring for refugees or immigrants or migrants, couple tips, again, as we've already stressed, really important to use qualified medical interpreters. It's important to ask about the patient's country of origin and travel history. That can be really important for a variety of reasons. Increasingly, as pharmacists take on primary care responsibilities, it's important to know some of the most common medical conditions, infectious diseases and parasites that immigrants and refugees are bringing into the United States. I'll give you a good example of that in a moment. Really important to remember that immigrants and refugees are particularly prone to depression. Many of them are victims of torture and have post-traumatic stress disorder. It's important to remember that many immigrants and refugees, as well as folks from many communities of color, use alternative medicines, which they oftentimes are very reluctant to disclose to their primary care providers and to their pharmacists, but their use of those alternative medicines or complementary medicines can contraindicate their use of pharmaceutical drugs. So it's really important to be asking patients about whether they are using those kinds of alternative medicines. It's really important to explore your patient's explanatory model. I'll talk more about that in just a moment. And finally, it's important to consider spiritual and religious beliefs that can impact treatment. Next slide. So there are a variety of cross-cultural implications for pharmacies and pharmacists from these changing immigration patterns, right? So it's important to be aware of at least some of the cross-cultural dilemmas that can occur when you're dealing with immigrants and refugees. One of those is cultural differences in patient expectations of the healthcare system. In the United States, in many Western countries, patients come to the healthcare system for a diagnosis. In much of the rest of the world, they come to the healthcare system largely for symptom relief, right? Cultural differences in medical decision-making is a big factor. Charla mentioned earlier on that, in the West, individual patients are believed to be the masters of their destiny, and so forth and so on, and make decisions on their own behalf. In many other countries and cultures, that's not the case. It may be an older member of the family or tribe or clan that makes decisions on behalf of patients. In some very male hierarchical societies, the husband would make those decisions on behalf of the wife. Differences in communication patterns. The United States although there are regional differences in the United States in terms of communication patterns, we are largely a direct communication culture. 2/3 of the rest of the world follow indirect communication patterns. So in many of those countries and cultures, they say yes. People will say yes when they mean no, because it's impolite to directly say no to someone's face. They may nod their heads when what they mean is, I hear you, not I agree with you. I already mentioned patients' use of complementary or alternative medicines. Important to be aware of that. Religious beliefs and practices can affect patients' use of pharmaceutical drugs. And some cultures definitely prefer shots or pills. You might want to explore some of those things going forward too. Next slide. I mentioned earlier the patient's explanatory model. What in the world is that? Basically, the patient's explanatory model is how they view whatever their healthcare problem, illness, or disease is. It's how they explain it to themselves, right? And that can be very different than the way that Western medical providers would characterize some of these issues. So just one quick example. It's one of my favorite examples. There was an older Hispanic woman. She was in her 70s. She had hypertension, and her hypertension could never be appropriately controlled until her physicians finally began to ask her how she took her medicines. And she said, well, you know, I've got hypertension, so I only take my medicine when I think I'm going to be under stress. So I take my medicine, you know, for example, when I expect my grandkids to come over. Her notion of hypertension, her explanatory model was that it was an episodic condition as opposed to a chronic condition. So exploring the patient's explanatory model sometimes can be very, very helpful in assuring that your patients are taking their medications as directed, right? So the noted medical cultural anthropologist Arthur Kleinman came up with some very helpful questions to explore the patient's explanatory model. Those questions are on the right side of this slide. What do you call this problem? What do you think has caused your problem? How serious do you think this is? What are the main problems that this sickness has caused you? What do you fear most about it? What do you fear most about the treatment, right? All good questions to explore your patient's explanatory model. Next slide. So what does the future hold? As we move now towards our Q&A session, I want to just highlight a couple final trends that we're seeing and some of which I'm sure you're already aware of, right? And the two that we want to highlight are the rapid growth of the primary care pharmacist and the rapid growth and need for education on global medicine, right? We know that many pharmacists are taking on primary care roles. The pharmacy profession is shifting from just a simple transactional medication dispensing role to a much more comprehensive patient-centered model of care. The American Society of Health System Pharmacists has outlined some of those shifting responsibilities. But since 2023 in particular, there's been a significant increase in both pharmacists and other clinicians who believe that pharmacists can and should take on a more primary care role. And the preliminary evidence suggests that pharmacists who are integrated into primary care can improve patient outcomes and satisfaction, but overall their impact on the healthcare system is somewhat unclear at this point, at least, right? Next slide. So I mentioned the rise of global medicine. This is largely due to a confluence of three critical trends: global warming, global migration, and dramatic increases in global travel, right? Around the world, 1.5 billion travelers cross international borders each year. Why is that significant? Because globally mobile populations increase the chances of pandemics because of increased spread. Lack of training in global medicine increases chances of misdiagnosis because many diseases of foreign origin share exactly the same symptoms as common domestic conditions, namely fever and a flu, right? So next slide. In medical school, many physicians are taught if it looks like a horse and it gallops like a horse, by God, it's probably a horse. don't be going out there looking for zebras, right? That was good advice when the world was less globally mobile. It's not such good advice today in light of global migration and dramatic increases in international travel. Because today, our physicians, our pharmacists are seeing more zebras. They're seeing more diseases of foreign origin in the US, which are very easy to misdiagnose. Let me just give you one quick example. I'm based in Minnesota. We have the nation's second largest Hmong population. People from the hills of Laos who came to the United States after the Vietnam War. Recently, we've seen growing numbers of Hmong patients in our hospitals who show up with what appears to be COPD, chronic obstructive pulmonary disease. Do they have COPD? No. What they actually have is an infectious disease, a parasitic disease called strongyloides. Strongyloides is a parasite. It can remain dormant in people's bodies for over 20 years. Long after the migration event, just when physicians are no longer looking for it, it can erupt. If you treat strongyloides with steroids, which is typically how you would treat COPD, it only disseminates the disease, spreads the disease, and kills the patient. We've lost 14 Hmong patients in Twin Cities hospitals because our doctors were not appropriately trained to recognize, diagnose, and treat strongyloides. So many of these diseases of foreign origin, malaria, chikungunya, schistosomiasis, the Zika virus, dengue fever, they all share the same common symptoms as fever and a flu. Be on the watch for those, right? Next slide. One of the things that we know, and from our research at BCT, we've actually published some research on this, clinicians who are trained in global medicine are vastly better prepared to treat globally mobile and minority patient populations. We found that they're more likely to use population-specific clinical best practices when treating globally mobile and minority patient populations. They're more likely to ask key diagnostic questions, and finally, they are much more familiar with infectious diseases of foreign origin. So when we talk about global medicine, we're really increasingly talking about 4 medical subspecialties of clinical practice. We're talking about travel medicine, tropical medicine, infectious disease, and parasites. Very few US medical schools, even today, teach global medicine. More are beginning to do so, but very few really focus on it. Sadly, when they focus on it, their focus is on global medicine in third world countries, as opposed to the domestic implications here in the United States of dramatic increases in global migration and global travel. So with that, let's turn to your questions, and we'll open up the floor for questions and answers. Any questions? You can either come up.
Hello, my name's Tom Young. I work for Family Health Centers of Louisville. I'm the language access director here. About 40% of our patients are LEP, and we have 3 pharmacies that are very active. My question is about the federal rules that came out this year about Section 1557. It specifies that machine translation cannot be used without review by a qualified human translator in situations where the translated material affects meaningful access to services. Despite this fact, every pharmacy I know either uses machine translation to translate their medication instructions, or they just don't translate medication instructions at all. Obviously, I think medication instructions and warnings clearly fall under information that would affect meaningful access. But how does a pharmacy like mine, which sees patients in around 70 different languages a year, how can we realistically comply with the law without having qualified human translators review every medication instruction and every warning in all of those languages?
Yeah, you bet. So it's important to understand, first of all, that the law requires that vital documents be translated. So it makes a distinction between vital documents and non-vital documents. Included in vital documents are patient discharge instructions, medication labels, and everything else. There are lots of language access companies that can help you not only provide interpreters in a whole host of languages over the phone or through video remote interpretation. Many of those language access companies also offer services in terms of providing written translated materials. But you're absolutely right, Tom, that Section 1557 offers some real cautions about the use of machine translation, because so many of those machine translation devices, particularly Google Translate, have been found to contain so many errors and inaccuracies. So it's important, as the 1557 regs suggest, to use a qualified human translator when serious consequences could occur.
Can I respond to that real quick too? With
Yeah,
regard
great.
to Envision America and scriptability, we have several levels of translation. Number one, we do use machine language models to do that, but we are adding just recently live validation and verification. That's one thing we do. We also have a full set of pre-translated sections of instructions, for example, that are already validated and verified by multiple translators for pharmacy related stuff. So all of our translations that are inside of scriptability can either be verified if it's a machine language version, or it is actual translations that were done previously that you can pull in. It's just a
Yeah.
comment.
So I see a question in the chat, and that question reads, if the company doesn't supply the information for this regulation, is the pharmacist still liable? Basically, what the federal and state language access laws all require is that you provide access to language access services, both to a qualified oral interpreter as well as to written translated materials. And as I mentioned, those written translated materials, the law makes a distinction between vital documents and non-vital documents. In those vital documents, yes, that includes medication instructions and drug labels. So yes, the answer to the question is yes, liability could attach.
Now, Dave, can you confirm this? In section 1557, and I think Medicaid as well, it's the top 15 languages in your state that we're going to be holding you accountable for, though, correct?
Yes.
So, you're not expected to do all 380 languages that are available in the United States, though that would be really amazing and true patient access. But they're not expecting anybody to be able to translate 380 different languages that are in the United States. And what we do at Envision is we've looked at the different state laws that have been passed, where the Board of Pharmacy is actually checking to see if people are providing this service, and we make sure that we're compliant with those languages. I think that if you have built-in translation information into your pharmacy software, I mean, I don't know for sure, but I'm pretty sure most of those companies, and Dave, maybe you know or not, they're doing something similar to us where they have had someone vet most of that information ahead of time. And same thing with the drug manufacturers that have translated information available on their websites. That's been vetted ahead of time as well. So there's different between pulling something off a vetted, translation site and then just having Google Translate do it. I hope that helps.
So there was also a question in the chat about the dates by which these new Section 1557 regs are going to take effect. As I mentioned, most of the regs have already taken effect as of July 5th. An additional set just went into effect on November the 2nd of this year. Thanks, Rika. Some of the ones that are still ahead will take effect on May 1st of 2025, as you can see on the slide. And then the training requirement That's a big one. That takes effect, have to have that done by July 5th of next year. Those written policies and procedures that implement the 1557 requirements, including that language access policy and procedures, those have to be in place by next July, as well as that notice of availability of services and auxiliary aids in the 15 most common languages, again by July 5th of 2025. Now, this question hasn't occurred yet, but I'm sure it's occurred to all of you already, right? Which is, what is the effect of the election? What impact is the election likely to have on these regs, right? So it's an interesting question, because the Section 1557 regs have been something of a political bouncing ball between Democratic and Republican administrations. So when the Obama administration came in, they increased the strictness of the Section 1557 regs. They required qualified medical interpreters. When the Trump administration came in, they loosened those regulations somewhat. They no longer required qualified medical interpreters. They simply required competent medical interpreters without bothering to define that term, unfortunately. And then just this last year, the Biden administration finalized those new Section 1557 regs that I've been speaking about, right? But it's entirely possible that the Trump administration would modify those regs again. And candidly, it's also possible, particularly if Republicans control all three branches of government, the executive branch, the Congress, and the Senate. And I know there's been some discussion about this, that the Affordable Care Act would be repealed in its entirety, which, as you can imagine, would just immediately eliminate these regs. Assuming that doesn't happen, which is just an assumption for the time being, it's important to note that it usually has taken these successive administrations at least 3 to 4 years to change the regs, because they have to go through a very extensive rulemaking process. So assuming that the Affordable Care Act is not repealed in its entirety, I would expect that these regs would remain on the books for at least the next 3 to 4 years. So I see another question here from Matt. Matt's question is, so if an independent pharmacy has more than 15 employees, we have to train someone to be a specific 1557 coordinator per the federal level? Yes. The answer to that is yes. You don't necessarily have to hire someone new to exercise that role, but someone has to be that 1557 compliance coordinator.
Any other questions? Well, we are certainly available to talk with you guys offline. Our information is up here on this screen. So I do community outreach. So, if you have a community event, I'd be happy to discuss, these things with your community. Also, our Vice President of Patient Care at Envision America, Amanda Tolson, can answer a lot of the pharmacy side questions when it comes to accessible prescription labeling. And David, you want to tell a little bit about what you guys are offering?
Sure. So at BCT, we provide language access audits to leading hospitals throughout the United States. Those are legal and best practices audits. They ask and answer the two questions you might already have guessed. First of all, is your organization in compliance with federal and state language access laws? Secondly, even if you are in compliance, are your providers using clinical best practices when they provide language access services to LEP and deaf and hard of hearing individuals? So we provide language access audits, we provide provider language access practice assessments and benchmarking. And finally, particularly in light of the new regs, we're increasingly being called upon by our clients to provide Section 1557 compliance consulting, audits, training, and other consulting on the new Section 1557 regs. So feel free to contact me. My contact information there is at the bottom of the slide, dbhunt@bctpartners.com. Would welcome any of your calls.
And finally, we are going to post this on the scriptability.com website as soon as we clean it all up and add some captions and everything. And we hope that you will share it far and wide with those who weren't able to be here. So thank you, everyone, for joining us.
Thanks, everybody. Have a great day.
Yep, thank you.
Thank